What are we talking about today? Dad joke. Wow. No, the fact that no one's laughing, I'm just gonna wait and be like, that's because they don't understand yet. Not because you don't get it. All right. The renal talk is scanning kidneys is a bit like potatoes. They're kind of boring. It's not a scan that you mostly get excited about. But every now and then you're like, wow, that's a really good potato. Just every now and then, right?
Like those potatoes that have like the kind of butts, or like the ones that, like they grow in funny shapes and stuff. You ever grow potatoes in your backyard?
I was thinking more about like when I say that's a really good potato, I mean like it tastes really good. Not, it looks like a butt.
It only tastes good because there's like butter and stuff on it. It doesn't taste good in isolation.
And that's why kidneys only taste good when there's pathology in them. There's a certain thrill in getting a really good apical four chamber. I've never seen anyone thrilled about, look at this long axis of the right kidney. But you got to know how to do it, and we'll talk about some cool stuff that you'll encounter along the way. Much less utility in renal scanning in kids than in adults, where stones are so much more common, and taking 2 seconds to be like, you have flank pain, you have hydro, is like transformative. But every now and then in kids, you'll get it too. So in terms of like the how to scan approach, we're mostly going to talk about these coronal cuts. So your probe's in that fast kind of position, the longitudinal plane, and you're going to put it on the patient's side, and you may need to kind of slide up and down, slide towards the head and towards the feet a little bit to catch the kidney exactly how you want it. One of the tricks for catching the kidney early, people often put the probe on kind of in a mid-axillary line, and then they look and they see their solid organs, spleen or liver, and then they see bowel gas. And their brain goes, well, that's not the kidney. And they're sometimes at a loss at the beginning about like, well, then what do I do? And they maybe do a little bit of stuff like this, trying to find the kidney. So bowel gas means you're in the peritoneum and not the retroperitoneum. So maybe a better approach is like, put your hand down on the bed, then push it against the patient, and then start to come up. Probably hit the view you want sooner. This is the kind of view that we're talking about, curvilinear, being used in the example here. And somehow in this patient, they're managing to get like no rib shadows, which is often something we struggle with. So nothing fancy about the anatomy. It's a kidney-shaped structure with a bright central collecting system with little dark areas within it where urine is accumulating and little dark areas in the cortex where urine is accumulating. And then a few things that are just like finesse tips. So the structure that's hyperechoic and kind of wavy deep down here, what is that? Yeah. And then the structure that lies in between the kidney and the spine is the aorta? It looks kind of striated. It's the psoas, because we love the psoas everywhere in the abdomen. Because psoas is a hip flexor, right? It's got to go down to the very proximal areas of your hip and pull it up, and it needs to be attached to something to do that. So it's spine down to hip. And you will sometimes find someone with like a psoas abscess in this kind of view. Rarely, unless you're seeing IV drug users.
Is the brightness inside just what is the material?
The collecting system, just the connective tissue core that is more like ureter, tubule, a bunch of smooth interfaces instead of a bunch of filtering, fluid-filled nephrons. And that's one of the things that this picture also demonstrates that comes into play in like the more subtle pathology. So you see these two organs. You got the liver and you've got the kidney. Which one looks darker? Kidney. Why?
Yeah.
More fluid, because it's your great filterer, right? That's all it's doing. Is it's like blood filter, urine. There are times you will see a flip between which one's hyperechoic. And it'll be this subtle thing that you may be like, there's something weird, but you can't really express why. That's pathologic. And normally it's the kidney that's pathologic. If your kidney's brighter than your liver, something's probably wrong with that kidney.
In babies, though, there can be a lot of, like, over the first few weeks of life, changes that happen. I forget which one it is, because I always feel neonate ones, but I'm pretty sure that it's the opposite of babies, because they're dry.
Yeah. Kidney's all slow, hasn't yet become the great filterer. Or you could be a 4-month-old who shows up all puffy and has this kind of scan. So what do people see here? What's this guy down here? This structure. Spine, yeah, making this striated wedge. Psoas. And what's this? Yeah, and this? Yeah, which one's brighter? Yeah, no bueno. So this was a kid with bilateral dysplastic kidneys who eventually grew out of its filtering function at 4 months and shows up with acute, but likely acute on chronic renal failure. Yeah, it looks distorted, right? Like there's no real distinction between the connective tissue center and how fibrotic and poor filtering this cortex must be. And then the other part, there's not a lot of scanning for ureter. You can try. You'll probably find you can see a tiny bit of it coming out of the kidney, and you can see a tiny bit of it behind the bladder, and everything else is obscured either by the muscular soft tissue that you got to shoot through if you're coming through the back, or bowel gas if you're trying to come in from the front. But scanning the bladder in a couple of planes is the other component to doing a renal or genital urinary kind of exam. And the bladder you're probably all used to seeing. Often I think of it as a circular, spherical kind of structure, but it's really not. It's kind of like trigonal, triangular. It has, as it fills, it has a very flat surface as it runs along the top. As it runs under the skin, under the subcutaneous tissue, it gets another flat surface at its superior roof, and then it kind of has a triangular wedged back. And in this image, we're starting in a transverse cut, and then the probe's flipping and going to a longitudinal cut. This is patient male or female? Female. So this is the uterus here, this kind of homogeneous, soft tissue, at times spherical appearing structure that if you turn your probe 90 degrees, takes on more of the typical appearance. So here's the uterine fundus is about to bulge there. This is the vaginal mucosa running up behind. Cervix is here where the uterus takes its kind of like 90-degree turn. As this bladder gets less and less full, that uterus collapses more and more and more until it's almost like 180 degrees folded on itself, and then it lifts up as the bladder fills.
So if they had like a posterior valve,
Mm-hmm.
valve, can you see it?
A posterior urethral valve, you'll see hydro. You may see hydroureter, and we'll get into seeing a little bit of what like a dilated ureter looks like in a bit. And just pointing out again that kind of triangular almost structure of the bladder. This is a longitudinal cut. We've got the vaginal stripe here running up, and then the uterus here.